Hey, good morning, everyone, and welcome to UroNurse. I'm your host, Vic Senese. Glad you can join us. If you're coming to us from live right now, you're watching us on YouTube, Facebook, LinkedIn, X, and Kick. So welcome to all those shows. Be sure to hit that subscribe button if you're watching us on YouTube. We're this close to 3,000 subscribers, so I know you guys can get me over the hump today. This is your first time watching us, be sure to check out our website at uronurse.com. Best place to go to catch all of our stuff that we've got going on, other good podcasts, what's going to happen next week. Check out our sponsors. Also, best place to go for all of our past episodes. This is episode 157, so there's 157 things to choose from. If you like to listen to us in your car, no problemo. We've got our audio podcast comes out shortly after this show ends. And we go on Apple Podcasts, Spotify, iHeart, Amazon Music, and YouTube Music. So just subscribe to any one that you choose, and it'll automatically come into your box. Hey, this Monday, we're launching our newest podcast, UroNurse News. It's going to be really cool, so be sure to check that out. You can go there and look at the website and see what stuff's coming up. But Monday, we launch 9 a.m. Central Time. We've got a great show for you today on UroNurse. We're joined by two leaders in advancing prostate care. Dr. Preston Sprenkle is a pioneer in focal therapy, an approach that targets only cancerous lesions, helping preserve sexual and urinary function while personalizing treatment for each patient. And presenting is going to be Jake Brumbaugh, Vice President of Global Marketing Oncology at AngioDynamics, bringing insight into technologies like NanoKnife that are reshaping the future of minimally invasive cancer care. So let's welcome both Dr. Sprenkle and Jake Brumbaugh to the show. Welcome to the show, guys.
Awesome. Thank you for having us, Vic. We're really excited to be here for episode 157. Also, I had a chance to listen to the back catalog and just love your mission of, educating, supporting, and inspiring urologic healthcare professionals. So we're glad to be here.
Yeah, we're glad. I'm glad to be a part of it and have something to do now that I'm retired. And I've been doing this for 3 years. So I did it before I retired, but I'm going to continue on. So now when people ask me what I do for a living, I say I'm a podcaster.
That's awesome.
Pretty good.
All right. So you're welcome to be on the show. Glad you could make it. Jake, I'm going to bring up your slides and let you take it over from there. Okay.
Awesome. Sounds good. All right. So there we go. Awesome. So thank you very much again, Vic. So for today's presentation, obviously this is episode 157, and really we're going to break this up into 3 separate sections. First, we're just going to have a discussion around prostate cancer, learn a little bit more about the disease state, kind of discuss the current paradigm of care. Second, we'll talk a little bit about focal therapy, the rationale around focal therapy and what exactly it is. And then finally, we'll end off the presentation talking a little bit more about the NanoKnife system and what this unique technology really is. So let's dive right in. So the first thing I want to talk about is really prostate cancer. And when we think about prostate cancer, there's really 3 main categories that really kind of define this disease. So first off, prostate cancer, as many of us know, is extremely prevalent. This is the most common diagnosed solid tumor in men in 112 countries around the world, and that includes the US. In fact, this year, around 315,000 men will be diagnosed with prostate cancer, and that number is up about 90% since 2018. Now, not only is the disease extremely prevalent, but it is also on the rise. Now, from a global perspective, they estimate that prostate cancer will double within the next 15 years. And interesting enough, there's really no public health interventions or lifestyle prevention measures that is going to reduce this rise in prostate cancer. And that's because prostate cancer is highly correlated with an increase in age. So just as our population continues to get older, as people continue to live longer, prostate cancer is something that is just going to be increasingly common within our society. And this is a real problem because prostate cancer can be extremely debilitating. We'll talk more about this throughout the presentation, but not just side effects from the disease itself, but also from subsequent treatments really can have knock-on effects for patients. These effects can take place from a financial perspective. They can impact a man's mental health, reduce their overall independence, And all of this has knock-on effects for family, friends, and the communities that they're part of. Now, in order to understand, why prostate cancer can be so debilitating and why it is so effective, it's best to understand how the disease really progresses. And prostate cancer can be defined by really two key criteria. First, it is a multifocal disease, and second, it's often very slow to progress. So first, when you look at prostate cancer right here in the middle of the screen in that box, about 90% of men are diagnosed with localized form of prostate cancer. This means the cancer is contained within the capsule of the prostate. But with that being said, it is multifocal, which means more often than not, there can be multiple lesions or tumors within the prostate. As a result, the standard of care is what's known as definitive therapy. This will be radical surgery, complete removal of the prostate, or radical radiation, complete radiation of the entire prostate itself. Now, on the other side of the coin, it can be quite slow to progress, taking anywhere between 10 to 20 years to become truly life-threatening. And because of this, for men that are diagnosed with low risk, even some lower intermediate risk disease, they might actually qualify for active surveillance. This is not a treatment per se, it is rather a protocol of repeat biopsy and follow-up to really actively monitor the disease and only provide an intervention once it is absolutely necessary. So when you think about the fact that prostate cancer is the only solid tumor that really has such a kind of a limited treatment path. So essentially for men, they have to make a decision. Are they going to move forward with active surveillance, not receive a treatment and monitor the disease? Or are they going to go forward with a definitive therapy, which completely removes the entire organ? And this can be kind of a challenging conversation and a challenging thought for men to decide between. So for those men that do choose to go on active surveillance, they really have to ask themselves the question, am I willing to go to all those physician appointments, to monitor the disease, and also to bear the burden of understanding that they are living with cancer inside their body. Furthermore, as you see here on the graph on the left, many of these men, about 25% will avoid treatment within their lifetime. But, at 5 years, around 50% of men are going to have to progress to some form of radical treatment that you see on the right. Now, for those men that are opting for a definitive therapy and they just want to get the cancer out of their body, they may move forward with surgery and radiation. And the challenge on that side is these treatments are extremely effective. They do a great job for patients, but they also can be associated with a high level of impact on a patient's quality of life. And when we're talking about quality of life, it's really two categories that we mainly focus on. First, we'll look at the erectile function or ability for a man to maintain the erection. And the second we look at is urinary continence, the ability for a man to kind of control his bladder. And as you can see, both radical surgery and radiation therapy can have a significant impact on those categories for men. And so essentially they're placed in this position where, should I treat my disease and face some of the quality of life outcomes that may change how my life is today? Or should I just actively monitor my disease, which can sometimes be a very challenging decision? Now, this is a unique situation, I think, amongst many solid tumors. So when you think about other diseases like breast cancer, obviously breast cancer has a very robust kind of treatment pathway with several different treatment iterations contained within it. You have the lumpectomy, which allows them to remove the cancerous tissue, but conserve the organ. You have the same with kidney cancer and the partial nephrectomy, or with liver cancer with your localized ablation. Essentially, every other solid tumor organ has a treatment that allows you to conserve the organ, but actually treat the disease. And unfortunately, that paradigm does not exist today within prostate cancer. Now, one thing that we have been focusing on over the past few years is historically, we've often measured the disease burden of different cancers by looking at, what is the incidence of it and what is the mortality rate. But over the past few years, the WHO have done a great job in really trying to understand the full disease burden. And that means not just looking at years of life potentially lost from a disease, but also the years lived with disability. And so when you look at prostate cancer actually tops the charts in terms of men living with disability. So the good news is men are definitely living longer and surviving through their diagnosis of prostate cancer. But one of the big challenges that we see is that these men are often living longer with disability, whether that be urinary incontinence, erectile dysfunction, or some of the other side effects which could come from these definitive therapies. So what we know is that prostate cancer is extremely prevalent. We know that it can lead to some side effects that can be challenging for men to deal with. And we know that right now there is no organ-sparing option that was available within this disease set. But over the past few years, 20 or so, there's been some advancements within clinical research and a better understanding of the biology of the disease. And this has really come to be known as the index lesion theory. And what the index lesion is that there's an increasing body of evidence that suggests for prostate cancer, metastatic disease is often caused from a single precursor cell. And that single cell is held within the index lesion, which is the largest, highest histological grade lesion inside the prostate. So understanding that the biggest risk to a man is that his disease could spread and metastasize, which would lead to eventual death. And in order to avoid that, if you could actually treat just the index lesion, you might be able to remove the metabolic potential of the metastatic potential of that disease. And so with the evolution of the index lesion theory, it really led to a new opportunity to offer a new type of therapy that spares the prostate or spares the organ, but actually effectively can treat and control the disease through the destruction of the index lesion. And that is really how we define focal therapy. So focal therapy is a middle ground treatment option. It sits between active surveillance and definitive therapy. And really the aim of focal therapy is to destroy the index lesion, but preserve the natural anatomy of the prostate and hopefully better preserve the continence and erectile function of the man. So this gives you a little bit of that in-between area where you are still able to treat the disease. You don't have to have the fear that you are living constantly with cancer within your body, but you're also not going full out and completely removing the prostate and facing the potential side effects that could come with that definitive therapy. And really what you see is there's been several advancements within the clinical community and the technological community that has led to focal therapy really becoming ready for prime time. And first and foremost, that came with an advancement in imaging. Over the past 20 years, you've really seen an improvement in transrectal ultrasound, 3D ultrasound that has allowed physicians to better visualize the disease. You also have improved MRI imaging, which really helps physicians locate and identify exactly where that lesion is within the organ. You pair this together with strong improvements within biopsy, such as transcranial biopsy. It means physicians are really developing better skill sets at really honing in on where is that index lesion and identifying it within the prostate. This in turn leads to improved patient selection, not only staging and grading of the disease, but really identifying who are those patients that best qualify for focal therapy. Because I will tell you, focal therapy is not for everybody. For those patients who do have very low risk disease, active surveillance is still going to be the best option to really ensure that they can maintain their quality of life. And for those patients that have some higher grade disease, higher up in the intermediate risk or high risk category, you definitely really want to move forward with that definitive therapy because of how strong the clinical outcomes there are for controlling the disease. But focal therapy really sits right in between those two, mainly for patients with intermediate risk prostate cancer. Now today, focal therapy has several different options. You can use cryo, which essentially is freezing the tumor. You have HIFU or high frequency ultrasound, which is burning the tumor or using heat to destroy tissue. And then you could also have a series of radiation, such as like brachytherapy, which could deliver a high dose of radiation directly to that tumor. But in all instances, the purpose of these focal therapies is to destroy that index lesion, but preserve the overall anatomy of the prostate. Now, one thing that has been interesting is that over the past few years, there has been a growing interest within focal therapy from the patient population But I would remind everyone that focal therapy, it still has very low adoption to this day, and it's still currently not within the standard of care guidelines when it comes to prostate care. Now on this graph, what you'll see in kind of that purple faded background is the rise in prostate cancer incidence. You'll see that dramatic jump from 2018 up to 2025. And then that blue line at the bottom, what you see is really the fact that focal therapy is offered by a few key centers around the country. Normally, I'd say these are definitely academic institutions that are delivering clinical research, that are really trying to best understand how you deliver focal therapy, what the right protocol should be, the patient selection, et cetera. Now, over the past few years, we have seen a slight uptick in focal therapy. We had the FDA recently release new guidance on prostate tissue ablation, which kind of helped clear the path for more companies and more technologies to come into the space. We've had AMA start to release new CPT-1 codes and improve reimbursement for these focal therapies, which should help the improvement in actually integrating this into a physician's practice. And we have had some increase in transperineal biopsy and MRI usage within prostate care. So we are just at the very beginning of the adoption of focal therapy, but based on all of the interest, the release of new clinical data, and the changes taking place across some of these government bodies, the FDA, AMA, et cetera, we do believe that focal therapy is only going to grow in its usage over the next few years. So before I dive into the technology, just a brief recap. Obviously, prostate cancer is extremely prevalent. Men face a challenging decision between active surveillance or a definitive therapy. And based on clinical research and advances in technology, focal therapy has really become an option for that middle ground of treatment. So with that being said, we'll talk a little bit about the technology today, the NanoKnife system. Now, before we go into the underlying mechanism of action and how the NanoKnife works, I did want to show you all a brief video so that you could really visualize and understand how the NanoKnife system works in a clinical situation. Vic, if we'd play the video, that'd be great.
The NanoKnife system is the only function-preserving therapy that uses electricity to destroy prostate tumors. The procedure takes about an hour and has minimal recovery time. During the procedure, electrodes will be placed to bracket the targeted prostate tumor. The physician will use ultrasound to guide the placement of the electrodes. This therapy precisely targets the prostate tumor with electrical pulses that destroy cells. Talk to your doctor to see if you are a candidate for the NanoKnife system procedure. Use the physician locator to find a physician who utilizes the NanoKnife system near you.
Awesome. Thank you very much. So as you can see, the NanoKnife system is a simple needle-based system, and the patient is laid in a lithotomy position, and essentially the needles are just placed and bracketed around the targeted tumor or the targeted tissue. At that point in time, electrical voltage is passed across those needles, and that is what leads to cell death. So the NanoKnife system is approved for the ablation of prostate tissue here in the US and internationally. And that talks a little bit about some of those new clearances that are really making focal therapy much more accessible to patients. Now, the NanoKnife system, as I said, is a simple needle-based procedure. It takes about 45 minutes to an hour, and it's outpatient. But the real magic of the NanoKnife and what people find most exciting is its underlying mechanism of action. The NanoKnife system is the only technology on the market today that uses electricity to destroy cells or tumors within the body. Now, this process is known as irreversible electroporation. So essentially what happens is that a physician will selectively target the tissue that he wants to destroy or she wants to destroy in the form of a tumor or just targeted area. Those needles are placed around the targeted area, and then electrical energy is passed across these needles. And essentially, you're just creating this big electrical zone. That electrical area essentially reaches a certain voltage, and it creates small defects within the cell membrane. So it's not like it heats them up or freezes them or anything like that. It just creates small pores in the lipid bilayer of the cell. At that point in time, the cell will essentially start to lose homeostasis as fluid transfers back and forth between those cells, and the cell will actually trigger its own apoptotic-like cell death. So when you compare this with heating something or burning something or even cutting something out using mechanical damage to destroy tissue, this is actually an extremely gentle method of tissue destruction. It's essentially just causing the cell to go through its apoptotic-like cell death. Now, the value of this, why does this matter? Why does it really matter that you are able to destroy the cell in that way? Is that essentially the electricity only targets something with a lipid bilayer, i.e., it only targets cells. This means within the body, if you have the lipid bilayer and that electrical energy hits it, you're going to have the holes form and the cell will die. But anything that is not made up of a lipid bilayer is not going to be affected by the electrical energy. And so when you look at tissue, tissue is made up of cells and then something known as the extracellular matrix or the underlying structure. This is protein and collagens, which make up the framework of our body. Now, IRE does not impact those proteins and collagens. And this means that it can be extremely versatile and safe where it is placed. So as a perfect example, you have the urethra. The urethra is an area that you definitely don't want to hit with any type of freezing or heating energy because you could potentially destroy it. With the IRE, there is actually physicians that could ablate right across the urethra. And yes, it will destroy all the tissue around it and associated with it, including the urothelial lining, but the underlying structure is preserved. And over the next few weeks to months, you will see the repopulation of cells along that lining that is going to allow it to maintain its form and function. So this means that it's a much more gentle method of tissue destruction. It allows it to be extremely versatile in where it's placed and allows physicians to really treat where the disease is located without being so careful or trying to really avoid those critical structures. Now, the majority of this evidence, the NanoKnife has been on the market since about 2008. Our initial location is we are mainly used within pancreatic cancer and the liver, where our technology is used to treat tumors that essentially were unresectable. You know, they're wrapped up around critical structures, and we were used around that. What we saw over the past 10 years was that a lot in our international markets, physicians or urologists were more frequently picking up the NanoKnife system and developing data with its use in prostate. So much so, we have about 30 publications covering almost 2,000 patients. Now, the majority of that evidence was done in our international markets. So just about 5 years ago, we took a look at that clinical data. We saw the excellent results that these physicians were gathering overseas, and we decided to replicate that research here in the US through the PRESERVE study. And this was really an attempt to validate the great clinical results we were seeing overseas here in the US. This was a prospective biopsy monitored cohort. We did the study in collaboration with the Society of Urological Oncology's Clinical Trials Consortium, and we had 17 fantastic sites across the country. We treated 121 patients and did 12-month follow-up. And what we saw is we were extremely excited to see the clinical results really were representative of what we had seen in our international markets here in the US. So just recently, our PRESERVE study was published in the Journal of European Urology. And what you see is that for men, when you look at the clinical outcomes from a quality of life perspective, we had about a 1.2% decrease from baseline in urinary incontinence and about a 9% decrease from baseline in erectile function. At the same time, we saw a strong drop in PSA, and we were able to control the clinically significant in-field disease to a rate of about 84%. So overall, we are extremely excited by the strong clinical results that the study established, especially considering that about 14 of the 17 sites that signed up for PRESERVE were actually naive to NanoKnife's use. This means that in a very short time, they were able to work through their learning curve, understand the technology, and use it to deliver these type of results for their patients. Finally, not just speaking only about the NanoKnife system, but in 2024, there was a recent meta-analysis that had come out that was really looking at all of the reported outcomes from focal therapy over the past few years. And what you see here in this chart on the left is essentially the function or the sexual function impact that focal therapy provides. And from an overall perspective, you're really seeing the type of quality of life improvements that patients are looking for. And then on the right, you're still seeing that strong level of control as these technologies work to try and control that index lesion in patients. And so from our perspective, not only through the contribution of our PRESERVE study, we really feel that focal therapy and its presence within the clinical literature is becoming more and more persuasive, which is good news for patients and good news for physicians that want to bring a focal therapy option into their practice. Finally, one of the challenges that we had talked about previously was focal therapy and its limited adoption wasn't just because of its need for indication or clinical data, but also for its ability for physicians to pick up this technology and patients to be covered under their insurance. As I said, AMA has been having several rulings over the past few years, and recently the NanoKnife system received its CPT-1 code. This will be going live in January of next year, and so we're extremely excited that patients will be better able to access this technology because they are now going to be able to have it covered underneath their insurance. And then finally, for my last slide, one thing I would say is we know that prostate cancer is extremely prevalent and that men facing this disease have some challenging decisions to make. We fully believe that focal therapy is an exciting new area of development, that middle ground that can really help provide a solution for these patients. But at this point in time, we're really in the early stages in the development of focal therapy. And this means that in order for us to be successful, we really have to make sure, Vic, just like the podcast here, we're providing strong education for physicians and for the urologic community. We continue to press forward in developing strong and persuasive clinical data, and we provide good patient outreach that helps educate patients on the potential treatment options they have. What does it mean to be part of a clinical study and further outreach? And really, how can we best support the urological community and better adopting and bringing focal therapy into the fold? And that's one of the things I do love most about working with my team here at AngioDynamics. We are the largest team that serves directly focal therapy here within the US. Every day we're in the field covering cases, working alongside our physicians, and even working closely with patients as they learn more about this technology and want more and more questions answered. So overall, focal therapy is an exciting opportunity. We think the NanoKnife system is a great option within the space, and we're really excited to see how the urological landscape progresses over the next few years as focal therapy becomes more prevalent and patients become more knowledgeable of their treatment options. That being said, that's my presentation. Thank you very much.
Oh, that was really great, Jake. I just want to make it clear for those of you that are watching live, you're free to put in the comments for Facebook, LinkedIn, StreamYard, Kick, any of those. If you're watching live, you can go ahead and put questions through the comments. If you're watching us on X, and I know we do have some out there on X, you have to go to one of those other formats in order to put questions through. So if you have any questions, let's go ahead and put those in. I'm going to kick it off and see who wants to take this one. So, focal therapy is not a new concept. It's been around for, at least I think 20 years ago, one of the Breaky guys was talking about why do we, radiate the whole prostate when we can really concentrate it on what's showing up as positive. So how does this differ from like some of those other focal therapies? And maybe Dr. Sprenkle, maybe you want to take that one?
Sure. So, I think, yes, the concept of this has been around for a very long time, and the desire for a targeted therapy in prostate cancer, the desire has existed. The issue, and Jake mentioned this a little bit, but it was really the revolution in imaging in around 2010, 2012, when we began using MRI for the prostate more concertedly. And that allowed us, that was really the first time we were able to look into the prostate and evaluate for that index lesion, evaluate for tumors and be able to see where they were. Prior to that, people were doing ablation therapies, but typically they were whole prostate or whole gland therapies because we just weren't confident that we knew where the cancers were. And as Jake mentioned, the disease, when we did remove the prostate, we found that cancer was multifocal. So there kind of been a few different things that have evolved over the last decade, 15 years. Imaging to see where lesions are, a better understanding that when we do targeted biopsies of these visible lesions, that sort of index theory developed from that, where we are seeing true biologic importance of imaging visible cancers. And then we've also gained more understanding of what is cancer that needs to be treated. So low risk cancers don't need to be treated, intermediate and higher often do. And we can provide those targeted therapies, like the index lesion is what's important because the low grade cancers are not. Treating them isn't going to change someone's cancer outcome. So you kind of asked, well, so, what is IRE? What is NanoKnife? It's actually been around for a while in prostate. I mean, I personally have been using it for almost 10 years now. We did have a lot of insurance challenges, so we didn't use it as much as some of the other technologies. But it is one of sort of, a handful of technologies that are very effective in providing this sort of targeted therapy. And as Jake highlighted nicely, we're starting to get a better understanding and, I guess, crowd swell a little bit of people asking for this. And that's really what is driving it so far. The evidence now is getting significantly better, and we hope to see some changes in the guidelines because that's what drives insurance reimbursement, quite honestly. Doing a lot of discussions with the insurers are like, well, until it's in the guidelines, we're going to keep giving people a hard time for this. So I think we're getting enough data now to show relatively equivalent success rates in terms of cancer control with things like surgery and radiation. We're seeing much lower rates of side effects. So again, not zero side effects, but the on average sort of impact on sexual function, impact on urinary function does on average seem a lot lower with the subtotal therapies than you get with a whole prostate treatment. So it's an exciting time.
So you and Jake both mentioned this term index lesion. Can you go in a little bit more about what that is? Is this an MRI sighting or explain that if you would?
Sure. So what we've seemed to figure out, and this is continuing to evolve, but often about 80% of the time when we are evaluating a man's prostate with an MRI, there will be one lesion that's larger. And when we do targeted biopsies and biopsies of the whole prostate as well, we find that 80% of the time there is really one area that has the highest grade and highest volume cancer. And studies have been done to show that the cancers, the genetic components or the genetic signature of those cancer genomic signature are of that index lesion. That is really where metastases come from. So by targeting and treating that index lesion, so the clinical pathway, someone comes in with an elevated PSA, they get an MRI of their prostate. If we see one area or the highest risk area, we can target that with biopsies, confirm that cancer is present there, but then treating that lesion, again, and more than probably about 80% of men will have this one area that is the high risk cancer. So active surveillance, ablation or a subtotal therapy is not appropriate for everyone, but almost 80% of prostate cancers will conform with that.
Yeah, thank you. That's a nice explanation. And then we do have a question that came in. So who is the ideal candidate then for NanoKnife therapy? Whoever wants to take that one.
I'll let the physician take that one. Yeah, I'll let you take that.
So from a clinical perspective, I think the men so a NanoKnife can be deployed pretty much anywhere within the prostate. So it is one of the ablation therapies that is really very effective no matter where you use it. So as Jake kind of mentioned, we can treat near the urethra. We can treat treat near the peripheral zone, near the nerve bundles. Because it has a precise margin of treatment, we can control that area quite well. So someone who's a good candidate would be someone with a prostate cancer that is localized to a relatively small area. Jake, you may know the numbers. I don't recall off the top of my head, but it's about, from a size perspective, we can treat up to 3 centimeters by 3.
Yeah, 3. So yeah, I'd agree. So about 3 centimeters by 3 centimeters.
Our maximal treatment area, about 9 cc.
Yeah. And, I think the only thing I'd add in is, I guess what I was passing over is, for focal therapy or for the candidates for the NanoKnife system, really anyone that qualifies for focal therapy, first off, based on how that physician kind of stages and grades patients, are going to qualify for this. Where the NanoKnife does come into play is, one, we're not contraindicated from calcifications. The size of the prostate is not limiting. It's relatively versatile. So normally when someone asks, hey, who's an ideal candidate or qualifying, it really is just those patients that best qualify for a focal therapy procedure, have the physician that feels well equipped to explain it to them, and options up for that. But there's no other limiting kind of features around the NanoKnife system beyond just qualifying from a focal therapy perspective.
Which is more of a discussion to kind of understand what that means. I mean, it's not easy or really appropriate for someone who needs a whole prostate treatment. I mean, there are some whole prostate ablation technologies that we can utilize to treat the whole prostate. But that's IRE or NanoKnife would not be my first choice in those situations.
Okay. Another question, what kind of recovery time can patients expect compared to more invasive procedures? What kind of recovery period?
Yeah, that's a great question. I think that's one of the things that differentiates the ablation procedures. So for surgery, typically it's a 4 to 6 week recovery just because of the incisions. It takes a while to heal and get back to full activity. With radiation therapy, depending on the intervention, it can be either treatment over 10 days or treatment over 6.5 weeks to even sometimes 9 weeks. And those are typically daily treatments, 5 days a week or so for some of them. So you're looking at a month and a half really for treatment and recovery. And even with the short interval of radiation therapy, there still is some fatigue and recovery after that for a couple months. With the ablation therapies, pretty much all of them are same day outpatient procedures. So you can have general anesthesia. You could have even some groups do it with spinal anesthesia in an outpatient clinic, not NanoKnife, but some other technologies like cryoablation or HIFU. But patients
NanoKnife is done under what anesthesia then?
General anesthesia, because it uses electricity, it can cause activation of the muscles in the pelvis. So we need people to be asleep for that and paralyzed. But we often do that anyway for many of the other ablation technologies that we use. But in general, in terms of the recovery, it's go home the same day. I personally leave a catheter for a week because I think that minimizes concerns with urinary retention. A lot of men are very concerned about a catheter. I can tell you it is annoying and a change. It is really very bearable, and having it in for a week is much better than having it out earlier and not being able to urinate and having the discomfort of being in urinary retention and then having to have a catheter replaced while you're awake. But after that week of a catheter, most men are able, 95% of men are able to return to their normal activities sort of in that week. And they often feel better than that even before the catheter comes out. I think that is one of the major things. We often hear reported cancer outcomes and continence rates and sexual function. And while those things are true, that happens over months to a year that we find that. But, the actual recovery from the procedure and the intervention itself is much faster with ablation therapies.
That's what most patients are worried about. What am I going to have to deal with?
Yeah.
When you're looking at all these therapies.
Yeah.
So I think we did kind of answer this one, only one treatment and how many treatments needed. So it's one and done, right?
Correct.
Right. And one of the defining factors I'd add there is so obviously the goal is capture large enough margin, single treatment, and obviously the physician will do the proper imaging and follow up to make sure that takes place. One difference that we think about when we think about focal therapy, especially the NanoKnife system versus radical, is you do have the potential option for repeat treatments. So,
Okay.
I think we had some clinical research done, it came out of Australia, but at 5 years, about 86% of patients didn't need a further retreat. But there is a group of patients that will either progress to either a repeat NanoKnife, or they might progress to a radical surgery, or they might progress to radiation. And so the one thing that is not often talked about, because obviously you want it to work great the first time and do all that, but one thing that has been powerful in our experience when talking with our patients is the fact that we have a lot of clinical literature that shows how tolerated some of these definitive therapies are after NanoKnife. So NanoKnife actually does not take future options off the table, whether it be the repeatability of NanoKnife or whether it be a definitive therapy. So on average, yes, one and done. But if there ever is a need to progress down the treatment chain, it's not like it removes your ability to have a definitive therapy in the future.
Great. And then we did have a follow-up to that. Any side effects? So you had mentioned urinary retention, leaving a catheter in. My question is, would they be a candidate if they wanted to learn self-catheterization? And could they go home without a catheter then? And then any other side effects you guys want to talk about?
Yeah, it's a really good, that is a really good subtle point. I personally try very hard to avoid intermittent catheterization. So I know some patients would be interested in that. Really, until after 6 to even 8 weeks, I would not recommend intermittent catheterization. The biggest risk is infection and causing infection, either a urinary tract infection or infection in the prostate. That really is what's going to lead to something like a fistula, like a really terrible complication, or major kind of pelvic damage, because there's going to be necrotic tissue. There's going to be dead prostate tissue there that needs to be reabsorbed and healed. So you do not want to get that infected. So I very strongly recommend against and will not do or allow my patients to do intermittent catheterization for at least a couple months. And typically anyone who is in retention, we've had a small percentage, but anyone who's been in retention has resolved by 6 weeks post procedure. So even if there is a prolonged catheter, it resolves by 6 weeks.
Yeah, that's great. And any other side effects that you're seeing? Risk of infection, you said would be one. So urinary retention.
Yeah, so I mean, the main ones we see most commonly are urinary retention. There can be, depending on the treatment zone, or very often I tell everyone you're going to have some decrease in your erectile function for a short period of time. I think that just relates to any intervention we're doing on the prostate. But especially if it's near the nerve bundles, there's going to be a decrease in the ability to get an erection. There is going to be a decrease in ejaculate volume. So semen volume is going to decrease. Anything you do to the prostate is going to decrease that. And ablation therapies are no different. You still may have some, I think with surgery and radiation, it goes away pretty much completely. With ablation therapies, you may have some ejaculate, but I wouldn't count on it. Urinary incontinence is more theoretical. I think, it can happen. In the PRESERVE trial, there was a small percentage of patients that seem to have some incontinence. Most often, I actually find that incontinence is not stress incontinence. It's not the kind that we associate with surgery. It's actually urge incontinence. People have a little bit more urgency,
irritation.
And so I do see some kind of increase in patients' urgency in that sort of 2 months after treatment. There can be some really symptoms of frequency, urgency, maybe even some dysuria. We'll evaluate, make sure there's not a urinary tract infection. But most often there's not. It's just the bladder healing and the prostate healing and kind of around the bladder neck. And so that can definitely occur. Those are really the main things. I mean, theoretically, haven't seen it much, but there can be some urethral sloughing, sort of some of that necrotic tissue can drop into the prostate and cause some blockage, but that seems to be quite rare.
What about your experience with, just a little bit of bleeding, pain from the needle placement, et cetera, just the overall comfort after the procedure?
Yeah, no, you're right. It's easy to kind of gloss over that, but there definitely can be some scrotal swelling, and there can be some hematoma in the perineum and in the scrotum, which I forget as a medical professional is really not normal, and people really freak out about that, understandably. But you can definitely get some scrotal edema and a scrotal hematoma, sort of an eggplant kind of looking scrotum, which can be very annoying or concerning. So we talk about that a lot too in the prep sessions.
All right, great. We do have another question that just came in. Patients can have a chance for TPR after NanoKnife. I think it's TURP they were thinking of after NanoKnife. So other procedures are still on the market or on the table.
Yes. Yep. So after NanoKnife and really any of the ablation therapies, it doesn't preclude you from other treatments. I think that's one of the great things about these ablation approaches. I tell patients that, this is, while it's still very effective, with 80% to 86%, as was in Stricker's paper, effectiveness and able to avoid additional treatments, this is the impact, as you were talking about, like you're home the same day, less impact on urinary and sexual function. Like this is something that we very easily can repeat multiple times. And the cumulative, and we're not really actually seeing cumulative negative impact on quality of life factors. I mean, it could potentially, if you had disease on one side than the other, and it causes damage to the nerve bundles. But if we're treating sort of the same area, the same cancer, there aren't really sort of stacking or cumulative side effects that we've seen so far when we needed to retreat people, which is, so we have that opportunity. We're not preventing surgery for radical prostatectomy. We're not preventing radiation. We're not preventing TURP if someone does have retention and needs that. Although very often for patients with significant urinary symptoms, they actually on average tend to get better because we're removing and reducing some of the prostate tissue. So we actually see most people's IPSS or AUA symptom score actually improves on average with most of these ablation therapies.
Yeah, makes sense.
And the only thing I'd add into that as well is, sometimes, patients will undergo these procedures, and as Dr. Sprenkle said, especially several weeks later, you feel back to normal, right? If for any reason patients do undergo other procedures or need other procedures, et cetera, such as like a TURP, make sure you are telling your physicians that you did have a focal therapy procedure beforehand. I think sometimes it kind of slips their mind, and you definitely don't want a TURP right after a NanoKnife or any other type of focal procedure. And so I think that's one thing to call out is it's still an invasive procedure, that you still want to give yourself enough space for. It's definitely not like something you want to pair right alongside it. But, that's just a quick call out.
And I do just want to voice some caution. I mean, I am obviously a big proponent of these ablation therapies. I'm very supportive of them. I think that they are a significant benefit as an option for patients, but they are not without the possibility of side effects. So these are not free. There's not like we're treating the cancer and you're going to have no side effects. Like that is not the case. I don't want to try to give that impression.
Yeah.
The risks on average and the percentage of people that suffer from complications are lower than the whole prostate treatments, but they are not zero. So this is not a free ride. There still definitely can be changes in functional outcomes, and it's less than you would experience, but I always caution patients not to expect it to be no impact.
Mm-hmm. With that, are there any long-term outcome studies on patients treated with NanoKnife? What's the longest study you have out there? What's the progression-free disease rate?
Yeah, it's a great question, and it's one that we've been really excited about. So as I think I mentioned earlier, we have about 30 publications out that covers probably more than 2,000 patients. The longest study we have right now is a 5-year median out of Australia, and the longest patients on those studies are 8 years. And so developing long-term data is definitely something that AngioDynamics is passionate about. So, we know we have some data that reflects about an 8-year. We're currently working with some physicians around some other experiences and might be able to pull out around the 7-year, but our median outcome is right around 5 years, which is kind of similar. I think you're either looking at between 5 to 10 years for different focal therapy modalities, wherever you are. So the improvement of long-term follow-up, understanding that, I think that's something that us as a industry and AngioDynamics are really dedicated to, and it's something we're going to kind of continue to really focus on. In fact, we are actually extending our preserved follow-up to continue to collect data from these patients and make sure we're developing and keeping that long-term data. So short answer, 5 to 8 years, or 8 years, 5 years median.
And what was the progression-free rate then at
so
the 5 years?
that 5 year is what we were citing. The 86% of patients did not need a retreat, need a new NanoKnife or progressive retreatment. But, that is it's a prolific site, a lot of patients, but it is a single center experience. So,
yeah, oh, great. I do have a couple more here. What are some of the common misconceptions about NanoKnife that you'd like to clear up?
Great question. Interesting. I think for the longest time, NanoKnife has a very unique mechanism of action. As I said, when you look at, let's say you go into your kitchen, I think everyone is familiar with freezing something, burning something, or cutting something. And so I think for a lot of physicians, it's very clear and very able to understand how a technology or how an energy source can destroy tissue. I think for the NanoKnife system, it works in a very unique way. Essentially, it's not killing cells. It's just putting holes in the cellular membrane, which eventually lead to a cell death. And so I think just the misconception that I'd like to clear up is just really nailing down that mechanism of action, how it leads to those holes forming in the lipid bilayer, and how that actually enables it to have a very consistent effect across the entire voltage area. When it comes to some other technologies and stuff, as you move away from a center area, so if like it's really cold in the center and it starts to get less cold near the edges, with IRE, you really don't get that. And so I think it's more just clarifying exactly what that mechanism of action is and how different it really is to anything else people experience in the real world.
Yeah, great. You have anything to add to that, Dr. Sprenkle?
I don't. I mean, I think, the IRE and NanoKnife is a very exciting technology. There are patients who ask about it thinking that it's going to, treat all of their cancer and sort of is going to seek out the cancer cells and treat it. I mean, I think that is possibly a misconception. It does still remain sort of a treatment of a volume or area of tissue. It is not prostate cancer cell specific. We do not have any cancer smart bombs at this point. Like that, that technology does not yet exist. It'll be great if we can figure that out, but it does not exist. So we still have to treat an area. We are always estimating where the cancer is. We cannot see all of your cancer. We see an area on the MRI where we think that it is. We confirm that by taking biopsy samples. We know that the MRI undersizes the amount of actual cancer that's in there from comparing MRI to prostate specimens. We've gained information about how much of an increased margin we probably need to take from where we see the lesion. There are actually some cool AI companies that are integrating the MRI, the biopsy information, and the ultrasound image to make heat maps of the extent of the cancer and how much area we need to treat. So I think that's an exciting area for the future. But, nothing right now, like for all the amazing advantages and advances that we have, we still have a long ways to go. So we are treating an area of the prostate. It's not a smart bomb. There still is a risk that it can come back. There still can be damage to some of the nerve tissue, to some of the normal tissue. So while this is kind of close to the best that we can do, it still is very far from perfect.
Yeah. So kind of when I started UroNurse, one of the things that I really was an unexpected event was finding out about all these little things that are out there for treatments that I didn't know about. And, and I've been in practice for 40 years, and prostate cancer therapy is just like boomed over the past decade. I mean, it's almost, I think it's difficult for patients to really make a choice now. There's so many choices out there. When you kind of weigh them, what do what do you tell patients? You could have this, or this, and hopefully there's more guidance that's provided by you as a doctor. But I think that patients are reaching out to places like me on the internet to find out more information, and I think it's going to be really confusing for patients with all these choices. So it's good and bad.
It is. Yep. No, I agree with you. I think it can be very confusing. We're very fortunate at Yale to have a variety of treatment options. So, I feel very lucky to be able to offer
Mhm.
multiple different ablation treatments to patients, so we can try to really personalize their care. In addition to, using one technology in a variety of ways, we kind of have a variety of technologies that we can use in a variety of ways. So I think I saw as one of the comments, it's great to have a full tool belt.
Yes,
And
exactly.
The only thing I'd kind of add in there is, when you think about BPH or something like that, they have a ton of different treatments. And I don't really think that, it drives too much confusion or challenges for patients. In fact, I think, over time, the patients have a better understanding of, are able to kind of navigate that alongside their physicians. I think one of the things is, I think for people in the know and people that are at academic institutions and someone like yourself that's often, evolved on the cutting edge of technology, Vic, when you look at the actual adoption rate of focal therapy and you think about the broader swaths of the country, the areas that maybe aren't near the academic centers, the areas that maybe have, service maybe a lower health IQ set of patients or, much more transient in nature, they really still don't have access to those different pieces of that information. So while it can feel exciting and like there's a lot of new technology coming out, the reason I wanted to highlight that number is I think in our community, we're definitely becoming more aware, but definitely in the majority of the US and the everyday shared experience of the patient, focal therapy is not something that is often being discussed. And so I think that is one of those interesting dynamics where I think it's becoming this really interesting topic in a small subset of the population, so it feels like everyone's learning about it. And so with that time, as we kind of expand and hopefully make our way more towards that community of care, we'll get better at communicating and sharing that. And I hopefully think it'll end up just very similar to a BPH type dynamic where, there's a lot of treatment options, a lot of different ways that patients qualify, and, you just work through it with the patient.
Yeah. So my wife was helping me to organize my workbench downstairs. She's going through my screwdrivers and she looks at it and she says, "What's this one for?" I said, "That's a standard screw. This one's a Phillips screw. This one's a star screw. This one's a torque screw." She says, "Why do you have so many for all these screws, these different bits?" I said, "Because they all do the same thing. Really, they do. But one has an advantage over another for different jobs." So I think that's the same thing here. So I'd like to thank you guys for all your presentation stuff. I'm going to go give a little plug for next week's show.
Incontinence care just got smarter. In this must-watch episode of UroNurse, host Vic Senese is joined by Kimberly Anderson, Director of Business Development at UI Medical, to spotlight the revolutionary Quick Change wrap. Designed to streamline incontinence management, Quick Change helps reduce caregiver burden, preserve patient dignity, and improve skin integrity. Whether you're a urology nurse, caregiver, or patient advocate, this episode dives deep into how Quick Change is changing the game for male patients with urinary incontinence. Join us on August 9th at 9 a.m. Central Time to learn more.
Hey, get ready for our August 4th launch. Here's a preview on what's coming up this week in UroNurse News. Coming Monday, can exercise really help you sleep better? Or is it just hype? Wake up to the truth, you might just be surprised. Mitomycin Reverse Thermal Gel. What does the latest Phase 3 trial reveal? Don't miss it. Tune in on Tuesday. Is soap ruining your skin? Dermatologist reveals surprising facts that could change your daily routine. Don't miss out Wednesday's episode. Overdiagnosed and overmedicated. The truth about UTIs in older adults. Are antibiotics really the answer? You want to find out more? You better tune in on Thursday. New research reveals SGLT2 inhibitors may actually help prevent kidney stones. These things are being used for everything. Tune in Friday to find out on UroNurse News, your daily healthcare news you can use.
From bladder to prostate, we've got your back. UroNurse News, we're on the right track.
So yeah, join us on Monday for that newest episodes going out. These are going to be daily episodes for 5 minutes or less. Everything you want to know about healthcare. So again, thanks guys for all your input. It was great. I think we had a great discussion. Yeah, I didn't go through all the comments that came through saying, thank you, so informative, great job. But we got a bunch of those too. So see everybody next week on UroNurse here